This is Dr. Jim Chappuis from Spine Center Atlanta. We're here today to talk about back fusions. Do I really need one? So I wanted to go into a little bit about back fusions, talk about the different types. Now, mostly what we're going to be talking about today are back fusions for the degenerative spine. We're not talking about trauma or fractures, deformity or scoliosis or tumors. This is purely, do I need a back fusion for some type of degenerative condition of my spine? And first, to start with, what is a back fusion? A back fusion, first when we say back, we mean lumbar, which is lower back area, L1 to S1. And a fusion means we're fusing these two vertebral bodies. The vertebral bodies are the foundation of the spine. And with a fusion, what we're trying to do is make two of these into one or three into one. So a fusion really just means we're trying to get these to stop moving independently. Now, the real question is, what type of pain are you having? Is it leg pain? Is it back pain? And what's the recommendation from your surgeon? The fusion either involves screws in the back like this, which are pedicle screws. It can be done from the front, which is known as an ALIF or Anterior Lumbar Interbody Fusion. It could be done from the side, which is called a Transpsoas Lumbar Interbody Fusion, which also generally is combined with pedicle screws, either on one side or both. So those are the basics of lumbar fusions or back fusions. So many times, especially with degenerative spinal stenosis, which is what we get into as we get older, a decompression alone can be enough. And by decompression, we mean open this part in the back up, because stenosis in general just means narrowing. So spinal stenosis means narrowing of the opening for the nerves to come through. It can be an opening out laterally, which would be a neuroforaminal stenosis, or it can be central or central canal stenosis. And so I think the biggest key for me as a spine surgeon is to trying to identify the quote pain generator or pain generators. We operate on patients based on their clinical symptom and signs. But the real question is, do I really need that fusion? And over the years, I think what I've discovered in my practice is maybe what we were doing 20 or 30 years ago was treating actually the x-rays as opposed to the patient. And so many times what I find today is when I talk to my patients and I see what levels are actually bothering them, I'm not always sure that a fusion is necessary. The real truth is many times a fusion may be more than is necessary. And that's the question maybe to your surgeon is, do I need that fusion operation? Would a decompression alone be enough? And then there's another procedure we do sometimes with the decompression. It's called a Coflex. And that's where a little metallic device is put in here after the decompression. And it's basically known as dynamic stabilization. So that's another option sometimes with degenerative spinal stenosis. The last thing I'll talk about is I'm sure people have heard about disc replacements. This is a disc replacement. They're being used very commonly in the neck, and they're being used cautiously in the lower back. And the reason I say cautiously is because if the disc replacement were to fail, to go back in the front part of the spine, there's scarring on all the major blood vessels and the ureters, so the revision can be very problematic. But again, these are being done more and more. I would consider this if it's the lower lumbar spine at L5-S1. But in looking at the results of a one-level lumbar fusion done through the anterior approach or approach from the front, the fusion rates with the use of BMP is close to 100%. Clinical success rate is in the 90% range. So I think these are questions that really need to be talked to with your surgeon. The other is, what are the complications from something like this? You know, to have a fusion, there's lots of complications associated with that. Now, you're going to hear that these are being put in by robots, by navigation, but they're still pedicle screws. They're screws that are put into the pillar of the spine. And then they're, in engineering terms, are cyclically loaded over time. And with that, if you talk to most mechanical engineers, they'll talk to you about how if one material is significantly different in strength than another material, and you cyclically load that over time, one of these is going to loosen or fail. In this case, it's the bone. The screw is obviously much stronger than the bone. So if this is cyclically loaded over time, these can loosen. They can cause pain. Now, putting these in, if the surgeon misses, they can go into the neuroframe and cause problems. Now, with robotics and navigation, that's less likely to happen. But still, there's a big paraspinal muscle on each side, and these screws impale that spinal muscle. And that in and of itself can be painful. Now, there's a number of lumbar fusions that are done with pedicle screws that are extremely successful. So all I'm emphasizing in this video is, first of all, doctor, do I need a fusion or is a decompression enough? And if I do need a fusion, what are the choices for fusions and what are the complications of each?